Hello, my name is David Bishop. I'm the District Anaesthetist for Mgungu and Global, and today I'm going to cover just a short period of anesthesia, and that is the induction of anesthesia to ventilation, just initiation of ventilation in the obstetric anesthesia patient. And what I'm hoping that you'll listen for in this talk is that you will try and evaluate what you are doing and change just one element of your practice that you see that you're doing differently. Now, when you put in a spinal anesthetic for a Caesar, about 5% of those will need conversion to general anesthetic or a repeat spinal. If you look at the UK data, in South Africa, it's actually probably higher. It's probably approaching 10%. So the risk of doing a general anesthetic is always there when you do a spinal anesthetic for a cesarean section. It's obviously there's a need to do them in the patients that have a primary requirement for general anesthetic as well. About 1 in 6 of your patients are going to drop their oxygen saturations below 90% when you induce them. This is data from Harry Gwala Regional Hospital, where there are registrars and consultants available, and we found that 16% of our patients drop their sats below 90%. If you look at the Cape Town data, in healthy patients it's about 13%, and in eclamptic patients it's closer to 20%. So there's a high risk of desaturation below 90% when you induce these patients. And by definition, they are difficult airways. You need to approach the obstetric patient as if it's a difficult airway for a multitude of reasons. Now, the Difficult Airway Society guideline, this is the society based in the UK, have released algorithms which are free downloads, and you're allowed to stick them up on your walls of theatres. You can laminate them. They've got algorithms such as this one. And I'm not going to be really going through these sorts of algorithms. They are self-explanatory, but I'm going to look at a slightly different approach to this. But it is worth checking out this website. Their algorithms are excellent, and the principles that these guys talk to are what I'm going to cover. Also, if you go and find this article, this is from the South African Family Practice that myself and Simon Leroux wrote. And here is an outline of how to do an anesthetic for a ruptured ectopic pregnancy. And really, this covers the whole of anesthesia for obstetric anesthesia as well, with 1 or 2 modifications that I'm going to discuss today. But if you've got this up in your theatre walls, it's a pretty good checklist for how you could do an anesthetic for an obstetric GA. Finally, this talk is available on this YouTube channel. It's by Dr. John Mark Tomlinson, and it covers an obstetric airway bundle, which is a concept he spoke about at SASA this year, 2022, and talks to all the modifications to the airway in an obstetric patient that potentially improve outcome. It's an excellent talk. It's 16 minutes long, and it's definitely worth listening to if you want to hear about some of the literature and some of the evidence behind some of these interventions too. So the first principle in preparing for an obstetric GA is to prepare your theatre. I'm going to go through that in a little more depth. The second thing is that you need to start examining airways if you're not doing this in a district hospital setting. I know that sometimes we forget this element in our pre-med visits, but examining airways is something you should do in every patient, whether you're putting a spinal or a general anesthetic into that patient. And I'm going to talk to some of the areas around what I think you should look for. And finally, you should plan a plan, and you should discuss the plan with your team so that everybody knows what you're going to do and what you're going to do when things go wrong, if they do. Now, the essential equipment list is part of planning for anesthesia, and it is part of knowing your theatre. So these lists are available from ESMOE. You should have these laminated as well, and somebody in your hospital should be designated to check that this equipment is available. But if you're walking into a theatre that someone else has checked, there are a few things that you really must look for yourself. You must be sure that you've got an ambu bag that is working. Test it. Include the patient end. Make sure you can generate a pressure. Make sure you have an oxygen source that you can attach it to. And just because there's a cylinder in the room doesn't mean it's got oxygen in it. Check the gauge. Make sure there's working suction, and that suction has a yankow that you can use to actually suction material out of the airway if you need to. And if I walk into a theatre and one of those are missing, I don't start. You must have those elements present at the very least. because when you get into trouble, if you've got bad equipment, you can mostly get around the rest. But if one of those is missing, you get into situations which are unrescuable. You have to get to know the airway trolley. And again, it's ideal if there's an expert in your theatre or in your hospital that is checking these things. But you need to be able to do that yourself to a degree as well. You need to make sure that you've got a working laryngoscope, ideally 2. You need different size endotracheal tubes, Guedel airways, and in particular, especially in an obstetric theatre, you need a supraglottic airway device, a ProSeal or an iGel ideally, probably a size 3 or an LMA if you must, but it's better to use a 2nd generation. And if you want to know more details about the airway trolley, there is a short video on the YouTube channel called the Airway Trolley Check, which is from the PMB Way, and it's just over 5 minutes long, and it will take you through everything that should be on an airway trolley if you work in a reasonable setting. It's really worthwhile getting this thing sorted so that when things go wrong, everything's available. Finally, you just have to get to know the anaesthetic machine. Again, the full machine check, really just 1 or 2 of you must know how to do this, but a basic check you really need to be able to do. And if you look at this machine, I've talked about this in one of the other talks as well, there's no circuit, the soda lime is exhausted, there's no power to the machine that actually catches people out, there's no vaporizer, there's no gas connected, and the APL valve is not checked. So these are the sorts of things you want to be able to do. Those elements you should be able to check. And before you start your anesthetic, just check, dial the APL valve down so that it's closed. Put some air in the bag and press that bag against your hand, so with the circuit occluded, to see that you can generate pressure. If you can do that, your machine is at least going to be able to manually ventilate the patient. And that's a check that I do in every anesthetic, even when I've checked the machine earlier in the day. And then you need to start looking at airways. Now, this is from the National ESMOE guidelines. It's a decent summary. It's got lots of good points on it. Another way to, and I suggest you go and read that. Another way to approach the airway is to evaluate 3 different areas of the airway every single time you evaluate an airway. And this is in the South African guidelines. The first is that you must ask yourself the question, am I going to be able to do mask ventilation in this patient? There's an acronym called BONES that we use for that. The B stands for beard, the O for obesity. With a BMI of more than 26, you're classified as obese in this classification. The N for no teeth, the E for elderly, and that's more than 55 years old by that classification, and S for being a snorer. And obviously in an obstetric patient, you're really just looking at obesity, the teeth, and the snoring aspect. And then also obviously there's things that don't fall into that classification, such as an eclamptic with a bitten tongue, or any other facial abnormality. And you must ask yourself, are there risk factors present that mean that that's going to be difficult? And that's the first aspect that you should consciously evaluate. The second is, am I going to be able to see when I do laryngoscopy? Now, if you look at the ASA guidelines, there's actually 11 things you're supposed to evaluate individually when you assess the ease of laryngoscopy. That's too much for a district hospital medical officer. I certainly didn't do this when I was in that setting. What I would suggest you do is you ask the patient to open the mouth. When you do that, you're actually evaluating a number of things, and you do a Mallampati score. I'll put that up shortly. While you're doing that, have a look at the teeth. You've actually evaluated a number of those criteria. Check that the patient can extend the neck. Sometimes you get caught here, especially if the patient's got long braided hair and they've got them in a bun behind the head. And it's very, very difficult to extend a head when there's that bun, so you need to make a plan. And finally, look at the thyromental distance. Again, I'm going to put up a little picture just now. So really, I would get the patient to open the mouth, do a Mallampati score, neck extension, and thyromental distance. So it's a few things. And if those are all in place, then laryngoscopy is hopefully going to be all right. And finally, is the neck clear, and will you be able to do a rescue airway in that patient? And if 2 out of 3 of these are concerning, you should consider referring the patient. So if you have time, so it's not an emergency, phone an anesthetic department in your referral hospital or speak to a friend, get help into the room and have a discussion. There are very few anesthetic departments that won't take a difficult airway. They will accept these patients very easily if there's time to move the patient. Sometimes you're going to have to go ahead. Again, it's worthwhile discussing these patients. Just to come back to those two things of the laryngoscopy, this is the Mallampati score. So when the patient, sitting up patient, not a lying down patient, opens their mouth, you want to be able to see the uvula. If you can only see the base or you can't see it, that's a class 3 or 4 and is suggesting that laryngoscopy might be difficult. And then this one, I find the most important one of all of them is the thyromental distance, the distance from the chin to the thyroid cartilage. And if that is 3 fingers or more than 6.5 centimeters, that's predictive of an easier intubation. Shorter than that, and it's going to be difficult. And if I can just warn you about these, when you've got a very short thyromental distance, when you put the laryngoscope in, the cords are going to be very anterior, and you're not going to be able to get around the corner. And these are the ones that worry me when you've got a short thyromental distance. So look out for that. And finally, have a plan. So this is the algorithm that I mentioned earlier and I put up from the Difficult Airway Society guideline. If you read through this, this is your plan. But you don't want to be reading this while you're doing this. You want to have thought about it in advance. So talk about what's going to happen. I'm going to do a rapid sequence induction after preoxygenation. I'm going to face mask ventilate. I'm going to attempt laryngoscopy at least twice. If that fails, I will put in a supraglottic airway device. If that fails, I will try and mask ventilate and we'll go to front of neck access. If everybody knows the plan and you follow that plan, then at least you're all on the same page and you've actually thought through the different steps, and you will also have checked for the equipment that's required for each step. So it's an important part of it, and you don't want to go down the failed intubation algorithm and you're thinking of it for the first time while the sats are dropping. Finally, for this section, there are guidelines for the whole of the general anesthetic for cesarean section. These are the ESME guidelines. Again, these are on the wall. They've actually got approaches to failed intubation and failed mask ventilation. It's got positioning, how to check the machine, all of that sort of stuff on here. And these things should be easily available for your staff. So just before we get to actually the induction of anesthesia, here's a few questions that I often get. Should you drape the patient first and then induce, or do you induce and then drape once you've secured the airway? My answer to that, there's actually good arguments on both sides, is that you probably shouldn't put a screen in front of the airway if you're an occasional anaesthetist. So whatever else you do, don't put that screen up with drapes on it that are sitting just in front of the patient's face, because when you get into trouble, that can make it more difficult. So I would advise, if you're a beginner anaesthetist, that you position ideally for the airway, you secure the airway, and then you start doing everything else. That's not a hard and fast rule, that's just my opinion. Should you use a wedge? Yes, you should. You still need to give that tilt, but if it ever interferes with the airway comes first. And finally, what dose of drug should you use to put the patient to sleep? I mainly just put this point there because it's not only about the weight of the patient. You calculate the dose that the patient requires based on weight, but then you must evaluate how sick the patient is. And remember that anesthesia is a titration. The same patient who's healthy needs much more drug than the patient who's identical, who is sick. And as a very rough rule, healthy patients get their full dose, sick patients get about a half dose, and critically ill patients get a quarter dose. Something like that. Remember, if the patient's had a cardiac arrest, like you sometimes see in high spinal, and the patient's unconscious, they do not require any induction agent at all. And probably another simple rule to remember in a district hospital is that if the patient's sick, think to yourself, should I be using ketamine? Because the dose of ketamine is less likely to cause a problem than an agent like propofol, which really drops the blood pressure. So now we come to the part of the procedure which probably scares people the most, and that is actually trying to get the endotracheal tube inserted. These are 4 areas which I'd like to encourage you to think about what you're doing currently and think if there's anything different that I suggested where you can perhaps change your practice. And I'm going to go through each of these points in detail, and they are that you should optimize your position, you should preoxygenate with care and potentially add something to that. There are rapid sequence induction adaptations you need to be aware of, and you should have a low threshold for a supraglottic airway device. So in terms of optimizing the position, think about how you induce your obstetric patients. Is the patient supine? Do you put anything behind the head? How do you go about that? And here are two things that I think you should do in all your patients. The first is that you should get the head elevated at 25 degrees. Much like you would have an elevated head in ICU, turn the head of the bed up to 25 degrees. And what that does is it improves the functional residual capacity. So it actually allows those lungs to open up a little bit more and potentially reduces your time to desaturation. And you should do this in all your patients. It may actually make laryngoscopy easier. So if you're not doing that, start doing that just for your induction. Once the tube's in, you can put the patient down again. The second thing is that you should ramp the patients, and that's different from this head of the bed elevation. Ramping is an attempt to get the mastoid process or the external auditory meatus, so the middle of the ear, in line with the sternum. And these pictures demonstrate how you can do that. So the patient in picture A is lying flat, and you can see that that ear is too low. You've got to ramp that head up, and you can either do that like in picture B with pillows and blankets, or you can do it with the actual head of the bed. Some of the beds will allow you to get it up at 25 degrees, and then you just put the final bit at the head parallel to the bottom section of the bed, and that will also allow you to do this. And you should do this in every single patient. If you have a difficult intubation and you have to reposition your patient, you have to ask yourself afterwards, could I have done that better? Because you must position the patient perfectly the first time. Now, in a district hospital, sometimes you can't get this equipment. I like this quote. It's from Lambert et al. In 2016. They said that the scarcity of pillows in resource-constrained hospitals should be regarded not as an inconvenient laundry issue, but as a serious lack of vital equipment. It is unacceptable to not have blankets or pillows to be able to do this. If you can't get the proper equipment, you can make it work with these sorts of things. Look how beautifully this airway has been prepared. That ear is in line with the sternum. You can see the thyromental distance has been maximized. That's a nice long thyromental distance, and this intubation I think is going to go fine. But if you put this patient on her back supine, it's going to be a disaster. It's going to be very difficult to see. So get your patient up at 25 degrees and then further ramp the head. The next element of these four components is preoxygenation. Are you doing it correctly, and are you using every element of preoxygenation that you can? One of those things that you need, A, good method, and B, you need a target. What are you trying to reach with preoxygenation? And these are the methods that have been shown that are to work, and you won't have all of these available in a district hospital. You will need to focus on two aspects, and that are the tight-fitting mask and the nasal prong oxygen. The other things I'll touch on briefly, but probably not available to you. A tight-fitting mask means that you put that mask on and you turn the oxygen levels up to about 10 liters per minute, and you watch the end tidal oxygen levels. And ideally, you're looking for an end tidal oxygen of more than 0.9. If you can get it above 0.8 as a minimum, but aim for 0.9. And that tight-fitting mask is going to decrease the time to desaturation. Secondly, putting on nasal prong oxygen is a step that's now recommended. And so you attach that to your auxiliary oxygen supply, which most anesthetic machines have, and you run that at 5 liters per minute. So you put the nasal prong oxygen on the patient, then you put the mask over that, and the one is running at 10 and the one is running at 5. Then once the patient's asleep, you take away the tight-fitting mask, and that nasal prong oxygen continues to deliver 5 liters per minute to that patient. And that is called apneic insufflation. And it means that while you're busy with laryngoscopy and trying to put the tube in, there's a continual oxygen supply to the back of that airway, which will then potentially delay time to desaturation, which is what you want, especially if you're struggling. And those two measures are possible at any district hospital. You should have the equipment to do both of those. Once you've pre-oxygenated adequately, you then move on. You need to consider at least some of the rapid sequence induction adaptations. Current method of doing a rapid sequence induction. Are you doing the traditional rapid sequence induction with cricoid pressure and no mask ventilation, 30 seconds that you're waiting for your sucks to kick in, or are you allowed adaptations? And there are two main things that I want you to consider when you do rapid sequences. The first is that cricoid pressure should be used, but you should have a low threshold for releasing that cricoid pressure if it's impairing your view or if it's preventing the tube from passing. It's important to use cricoid pressure, but sometimes it causes more problems than it solves, and releasing that cricoid pressure is increasingly recognized as an important part of putting the tube in. So be prepared to tell your assistant to take that cricoid pressure off if you need to. The second thing is perhaps the more important thing, and that's called gentilation. And this is the concept that when you put a patient to sleep, they go off to sleep and you're waiting for the muscle relaxant to work. In that period, before you attempt laryngoscopy, you should provide gentle mask ventilation to that patient. And by gentle, I mean you shouldn't exceed pressures of 20 centimeters of water, and you just give the patient a few breaths with 100% oxygen while you're waiting for your muscle relaxant to kick in. Now that does a number of things. It firstly continues to oxygenate a patient who's prone to rapid desaturation, so your patient's less likely to desaturate. It reassures you that you can mask ventilate the patient, and it provides apneic insufflation even if you can't get air into those lungs. And the Difficult Airway Society guidelines recommend you do this gentilation, or you at least consider it, in obese patients, in patients with reduced functional residual capacity, with a higher metabolic rate, or a potentially difficult airway. And if you think about the pregnant patient, quite often you're on 4 out of 4 and always on 3 out of 4. So this is a practice that I do in every single obstetric GA that I do, and I found it really makes a difference, and it's something that you should consider. And finally, you need to have a low threshold for a supraglottic airway device. So this is something that is increasingly recognized as having caused problems, where people have just continued to try and intubate the patient and they haven't switched over to a supraglottic airway device. And while I don't want to encourage using them as the primary airway device, there are countries in the world where using a supraglottic airway device, they're used routinely in elective seizures, and they don't even try and intubate the patient. And the morbidity and mortality attached to these devices is actually lower than with an endotracheal tube. So while the South African guidelines still say that you must intubate the patient, when you're struggling, it is not considered a failure to put in that supraglottic airway device. It's something that should be, I've tried twice, now I'm going to move over to this device. And I think sometimes people forget about that until they're in a cardiac arrest situation. Now, if you look at our ESMO-E failed intubation drills, point number 6 is insert an LMA, and they've got there in yellow, do not keep on trying to intubate. It's a common error. If you look at the master algorithm from the Difficult Airway Society guidelines, just to reassure you that on rapid sequence induction, they mention face mask ventilation. So that's not something that I've made up. It's actually from a guideline. And they talk about putting in a supraglottic airway device. And that's after 2 intubation attempts have failed. You should put that device in. So these are accepted guidelines by airway experts. The goal is to ventilate and then oxygenate your patient. It's not to intubate. If you can't intubate, you just need to find some way to ventilate the patient. And that can be with mask ventilation or with a supraglottic airway device. So once you successfully intubate the patient, you secure it and confirm its position. Confirming its position there are a number of ways you can do this. If I can just mention the ones that I think are important, put the tube in, and when you manually ventilate the patient, the chest must move. The tube should mist. You see that water vapor in the tube. There should be capnography. There should be sounds on both sides of the lungs, so you should listen. And there should be no sounds in the stomach. And finally, the patient should stay oxygenated. I want to caution against using oxygenation as your primary method of confirming the tube, Because what happens is if you've done your preoxygenation right, the patient might actually take minutes before they desaturate. So that must be your last monitor. For sure, if the oxygen continues to drop, then you should suspect the tube. But don't be too reassured by saturations that are in the 90s when the other things are absent. So quickly and efficiently evaluate the position of the tube is very important. And finally, switch on the ventilator. Now this will be a button or a switch, and it often needs to be confirmed. You need to know your individual ventilator, check that the ventilator is working and is delivering the settings that you've put on. I would suggest settings such as this: put a tidal volume of 400, a respiratory rate between 12 and 16, PEEP of between 5 and 8, and oxygen of initially 100% that you dial down to 40% once you've confirmed that the ventilator is working. Choose an SIMV mode. It's a synchronized intermittent mandatory ventilation. The reason that I suggest that is that then when the patient does start to breathe, the machine will support those breaths rather than a mandatory mode. And just remember that if you put on the ventilator and nothing is working, you're not delivering any air, but you're sure your tube is in, go back to manual ventilation. And if you can manually ventilate the patient, then you've got time. You continue to do that. You can even finish the CESAR on manual ventilation, or you can try and initiate ventilation again. But if the ventilator is not working, go back to your manual ventilation, and then afterwards work out how the ventilator is working and whether there's a problem, whether it's you or the machine. And if you've never used the ventilator on your machine, you should practice doing this before you do a GA. Attach the circuit to a false lung, which is just a bag. Let it ventilate that bag and practice setting it up so that when you get to this component of the anesthetic, it's easy. And it really is an easy thing if you've done it a few times. And use those settings. They're also in our article that I mentioned at the beginning on the ectopic. And this range will sort out 95% of patients. Finally, don't forget to phone a friend if you get into trouble. There's often pauses in anesthetics or times where you think, okay, we've got some time to phone now. Phone someone. You're welcome to phone me, but ideally phone someone at your regional center. And if you think about a problem that you don't understand what happened, but now the event is behind you, feel free to email me and ask me questions. I'm very happy to take them. Thanks very much.